next on the topic of myopia control through contact lenses, effectiveness, mechanisms, and clinical insights. I have the pleasure of inviting on stage the chairman of the 18th Annual Scientific Sessions. Please put your hands together for senior optometrist Chanaka Veerasundara.
So thank you very much for kind introduction. So today, why I selected this topic, wherever we go and participate for a scientific forum in optometry, the talk of the town, I would say, or many people talk about this managing myopia or controlling myopia. So I thought of giving not a very lengthy discussion, and we can talk about this topic length to length, but giving some glimpse for our dispensing opticians, because now we have, in Sri Lanka also, we have started prescribing and myopia lenses, myopia management lenses. Right. So I am trying to mention here some names. The company or brands names mentioned in this presentation is not on, it's only for information purpose. So there's no financial disclosure whatsoever. So I'm not going to give a definition of myopia, but you know, myopia is which you can see up close, but the further distance is blur. You can see up close very well, but the distance vision is blur. But there is a definition of myopia also. And it has been categorized with the power, the high, low, and moderate myopia. Minus 0.25 to minus 3 is low myopia, and minus 3.25 to 6 is moderate, and above minus 6 is we consider it high myopia. So, why this is a concern? Myopia, growing myopia or the progressive myopia, why is this a concern? Because of the prevalence in the World Health Organization predicts in 2050, that means 25 years from now, the half of the world population will be myope. And already now, as per statistics, 1 out of 6 person here is a myope. Now is 1 out of 6 is a myope, but in 2050, half of the world population will be myopes. So is there a problem being a myope? Now the problem is, if you become a high myope, there are a lot of consequences. And World Health Organization says now it's actually healthcare concern around the world, this progressive myopia. Especially in Southeast Asia, even you can see the stats on the slide. I mean, they have high prevalence rate of myopia. So the risk factor, you all can see, as I mentioned earlier, the consequences being high myope, being a low myope to high myope, the cataract development, the glaucoma, the retinal detachment, and myopic maculopathy, which going to be a cause of a blinding cause in those people, in high myopes. So in 2050, so healthcare professionals has to more concern about the blinding people with high myopia. But the early intervention, so if we really concern about our myopic people, if we can find it out who are at a risk of developing high myopia, so we can control them. We can just postpone that myopia, because every diopter which increases matters. Every diopter which increases matters for these risk factors. So, what we did earlier is just providing spectacle lenses just to see better. But myopia management is providing correction plus controlling. Main concern is the axial length elongation. You know, once a child born, they born with a short eye, so they are hyperope. So the emmetropization happens, that means over the period of time until about 6 years of age, the axial length of the eye get little by little longer, and at age of 6, they will develop the 6/6 vision, that is minimum normal vision on a person, minimum normal vision. But if the axial length going to elongate more, that's a risk. So I have a lot of statistics, but because of the time concern, I'm not going to go in very detail. So who are at risk? Who are at risk of this myopic progression? The children, those who are more indoors than outdoors. More indoors than outdoors. And exposed to less ambient light in classrooms. Now, I have a habit, wherever I go, I have an app, I just measure the how much of intensity of light it has. Actually, on a room light condition, it should be at least about 400 to 500 lumens of light for better seeing. Actually, light will play a very big role in someone's vision. Actually, it's in human beings, it's play a big role. But when you go out from a room, the lumens will go up to 30,000 to 100,000. So there's a very much of ambient light conditions there. So which is very important. That's why they say a natural light is better in controlling this axial length elongation. And actually the myopia, it's not a refractive error anymore, it's a lifestyle change, right? So, and some children, there's a study in Singapore, the children, those who are getting into education very early, like from 1 to 2 years old, they do a lot of near work. With the Sydney study, they have done a study from Singapore and in Sydney, the Singapore people becoming more myopic because they start learning early. So a lot of near work also not good. Lot of near work not good. Getting closer to reading materials not good. So at least the children, minimum per day, they have to be outside with ambient light. 2 hours per day in ambient light, they have to be out at least. So then we can actually educate our children as well as parents in this concern. So living in urban spaces are greater risk of becoming myope. Now you all have seen urban areas, even schools, the classrooms are by about 10 by 20 and is well covered classrooms with 1 or 2 fluorescence light, which is actually not a good thing. But in rural areas, have you all seen the schools with half walls and they can see out? And even in China now, they are making classrooms with glasses and to have a lot of ambient light, because light is very important. And the parental myopia, the father and the mother, if they are both myopes, the child has a 30% of risk of getting myope. So that's a genetical factor. And as for optometrist, when you are doing retinoscopy and all, you have to more concern a lag of accommodation. The accommodation lag. Every myopic child is not a progressive myopia. that we have to remember. But if we find these risk factors, so we have to intervene and we have to provide the myopia management solutions. Now, how to do that? There are different ways of doing it. I'm just giving you two factors here. You can see whether there's an accommodation lag. So, when you're doing retinoscopy, especially when you're doing dynamic retinoscopy, you can find the accommodation lag. The people with accommodation lag, they are at greater risk. And the same time, ACA ratio, accommodation convergence to accommodation ratio, if it is more than 4 to 1, of course 5 to 1, they are at greater risk. These things I have learned very recently at Academy of Myopia Control and Orthochirurgy. Our associate professor also there, who gave us a fantastic lecture on that. Thank you very much, Maharaj. And here, so how this myopia get progressed and how this axial lens get elongate. Now, you know, when we just give a piece of lenses for myopia to see, the central rays of, you can see the central rays of light and comes and focus exactly on the retina, but the peripheral rays is focusing beyond the retina. Beyond the retina means away from the retina. So, we call this a hyperopic defocus. So, the axial length elongation and the hyperopic defocus. Hyperopic defocus means this peripheral light rays are focusing beyond the retina. So, that's the stimulation to grow the eye length to get elongate. So, what we do with these myopia control lenses or myopia management lenses, or there are different types. I am not going to talk about the atropine penalization, because I am just mainly want to give some advice to our dispensing optician and optometrists. So, this hyperopic defocus, we should take it inside the retina and to become a myopic defocus. Then that stimulant won't be there, so the axial length elongation won't happen. So, hyperopic defocus, we have to take it to as the myopic defocus. So, there are children we can exclude providing these myopia control devices. It's like congenital myopia, pathological myopia, and you can see all these things I have listed down on here on this slide. So, every child should not provide with myopia control lenses. You have to pick who is going to progress the myopia. So, this is again the sketch, you can see exactly what I said here. This is hyperopic defocus, that we had to make it a myopic defocus. So, when the myopic defocus happen, so axial length elongation get controlled. So, these are the options available right now in Sri Lanka, except one will be available very soon, which is right at bottom here. But the DIMS technology, defocus integrated multiple segments, and the whole technology we have now, which is highly experienced lens target technology, and the KR cylindrical annular refracting elements, these three lenses are here in Sri Lanka, which our optometrists will provide. The dot technology is still not available, no sooner it will come. So, and contact lenses, these are a very important part. So, I thought of emphasizing more on contact lenses, but the time is running out. But we do the multifocal lenses for myopia progression. But not every multifocal is. There are two types of multifocal contact lenses, which is center near and center distance. So, we have to pick the center distance one, not the center near, because which is widely available is center near one. So, we have to pick the lens center distance. So, there are different types you can see. So, because of the time concern, I just run on the slides. And the extended depth of focus multifocal lenses also there. So, those are very effective, and clinical studies have been shown greater results. And the orthokeratology, you know, the cornea is steeper in the center and flattened towards periphery. That's a normal geometry. But this orthokeratology are based on reverse geometry. That means center flat, peripheral steep. Center flat, peripheral steep. And that you have to carefully do this. You have to have a good practice to do it. Little time concerning in Sri Lanka, that we are having a problem with getting down the lenses, which is at least now a custom-made lens take about 2 months to come. So we are little, in back, actually behind when we compare with other countries. So this has to be practiced with a lot of clinical expertise, but it's a clinical study says a great option for myopia control. And here I have given some statistics. The atropine and the combined therapy is actually more effective. And I'm not going to talk about atropine. So the normal lenses is only about 0.5, but the spectacle lenses spares 12 to 55%. Soft contact lens and multifocal 29-60, and ortho K it's 32 to 100. And this all the lenses what we have, spectacle lenses, the whole technology, the care and DIMS technology, it controls nearly up to 59 to about 67%. So thank you very much for patient listening. Because of the time concern, I just ran on the slides. Thank you very much.